So Dr. Malekzadeh is a professor of the Digestive Disease Research Institute of Tehran in Iran. And the institute he founded in 2000 and has since expanded it much, much further. So the main field of interest is really gastroenterology and the cancers of the digestive tract. And during his career, Dr. Malekzadeh has, gained much more interest in chronic disease and prevention with a special interest in non-communicable diseases. Has supervised and conducted several epidemiological clinical studies, and I guess what is really important for this educational webinar, established the first large-scale cohort study in the Middle East and North Africa, the Golestan Cohort Study. So he's a member of many large-scale international collaborative studies looking at cardiovascular disease, cancers, and other chronic diseases, and really looking at environmental and genetic risk factors for chronic diseases as well as metabolic system and the syndrome. So Dr. Malekzadeh has started two different cohort studies. One is PARS in southern Iran and Golestan in northern Iran, looking at really the chronic disease and prevention. And I'm not going to talk about the trial that he has set up regarding prevention of cardiovascular disease and other diseases. So it's a large trial from recruiting participants from over 20 different provinces. So really much looking forward to hearing about your research, Dr. Malekzadeh. And today we are going to hear about using the IHCC to prevent premature death around the globe. Welcome.
Okay, good evening, everybody. Good morning, everybody. It's a pleasure for me to present on my interest on preventing of premature deaths around the globe. As you know, I have no disclosure disclosure or conflict of interest to disclose. As you know, one of the major problems we had in the present world is the premature deaths. Premature deaths, by definition, is the death under 70. But many people in the world are dying of before 60, 55, or 60. One of the major public health focus of both all societies, both WHO and other health institute, is to prevent the premature deaths. Premature death is really very bad because you lost the middle-aged family member who is working for the family, and decrease in income, poor loss of education and childhood. Therefore, this is really a major problem for all families who lose one of member, especially the father from premature death. As a matter of fact, the cardiovascular disease is the etiology of premature deaths in 123 countries. The majority of 54% of all deaths are premature, means that they are less than 70. These estimate, of course, for developed world is about 28%, while in developing countries, it's about 80% of the deaths are premature. And ischemic heart disease and stroke are the leading cause of the premature deaths in the globe, especially in developing countries. 80% of the premature deaths are occurring in low and middle income countries. Over 60% of the global burden of the coronary artery disease are in this low and middle income country. This is mainly due to growing age, lower access to physician, more difficulty in tailoring treatment. And actually, we need a new paradigm to prevent this cardiovascular disease. Iran is a middle income country which had about 84 million inhabitants in 2019. Life expectancy in Iran is 79.6 for female and 76 in male. But the rate of premature deaths between 30 and 70 years are in 2017 is 47%, and 47% of the Iranian are die of premature deaths. According to the SDG target, the share of premature deaths should reach to 11.6 in 2025 in Iran, which is, we are far behind this target. As the top-ranked NCD, cardiovascular disease cause about 55% of all premature deaths in Iran. This is the data from one of the major heart centers in Iran, the so-called Tehran Heart Center, a big hospital which only cares for heart disease patients. As you can see here, the coronary artery bypass graft surgery in Iranian occurred 10 years earlier than the European country. The only country which is close to Iran is Armenia, which we are genetically very close. Therefore, in Iran especially, we have this major problem of premature deaths. And here again, you can see the distribution of coronary artery disease in year 2002 and 2019. And as can see, even in minus 40 to 51 and minus 56, both male and female, there is a significant people who come with cardiovascular disease prematurely and in the early age. If you want a figure, we have about 154,000 deaths from cardiovascular disease, which 50,000 are under 70 and 12,000 are under 50. Therefore, this is really a major health problem. You may want to know why, as a gastroenterologist, I became interested in this issue because, as you probably know, esophageal cancer, ESCC, squamous cell cancer, was reported to be very common in this part of Iran, northeast Iran. And I was always interested in understanding what is the etiology of this high incidence of esophageal cancer in northeastern Iran. As you can see, this is there from the cancer registry by IARC in 1970. And there were some studies at that time, but they stopped the study after the revolution. Therefore, we started this study of Golestan Cohort. That province is called Golestan. Therefore, we started a cohort study. We call it Golestan Cohort Study, which is presently an IHCC member. In 3 years, 2004 to 2008, we recruited 50,000 adults in this high incidence area, both Gombat city and 326 villages around that area. And we completed the lifestyle questionnaire, a food frequency questionnaire, and also collected the biological sample, including blood, urine, hair, and nail. And after about close to 15 years of follow-up, we had about 10,000 deaths in this cohort. And as you can see here, about 50% are due to cardiovascular disease, the deaths. If I show you this table, it's very interesting that we were looking for esophageal cancer, but esophageal cancer was the etiology of less than 5% of deaths in the Golestan cohort. And about 50% of the etiology were ischemic heart disease and stroke. Therefore, at this point, I thought that we should do something for ischemic heart disease and stroke. And as a matter of fact, it's more simple to prevent those. This cohort actually was, and 63% of the people in our Golestan cohort die prematurely. And more than half of them are from cardiovascular disease. Therefore, this was the reason why I decided to spend time and see whether we can prevent cardiovascular disease or not in this cohort. Prevalent cases of total cardiovascular disease in the world, if you just look at the world, the cardiovascular disease nearly doubled from 271 million in 1990 to 523 million in 2019. Therefore, this is a real epidemic. Number of cardiovascular deaths steadily increased from 12 million to 18 million in 2019. Therefore, I can say that actually the biggest epidemic in the world is no cardiovascular disease, and this is what is the etiology of premature deaths. And this why we don't have enough cardiologists, hospital, and care for this huge number of people with cardiovascular disease. Looking at the United States of America, as a matter of fact, United States also, the life expectancy has declined, especially in, it is less than other high-income countries. And this underperformance compared with other peer countries is growing because of concern, as has motivated people to do something for it. The current gap between life expectancy in the United States and peer country are the largest ever recorded. You can see here, this is the United States, the red line, and the yellow line is their peer country, means European country, and the performance in the United States is also lower than peer country. Therefore, we have 18 million deaths. Over 30% of all deaths are due to cardiovascular disease, 14 million non-fatal cardiovascular events, 423 million prevalent cases of cardiovascular disease, and actually the biggest epidemic in the world has ever seen. And this would, of course, result in shortage of cardiologists and specialists. It has a huge financial burden, even in high-income countries. Look at the figures for UK, France, Germany, Italy, and Spain. They spend a huge amount of their budget on treating this cardiovascular disease. And unfortunately, poor people are dying more of cardiovascular disease. And the heart disease is leading cause of deaths among women worldwide, with an estimated 8.6 million deaths each year. And we have, of course, a target, we call it SDG, Sustainable Development Goal. We were supposed to have a 30% reduction in premature mortality due to non-communicable disease. This is what majority of countries and the UK, United Nations, and WHO has agreed upon. But we are actually far from this target, as I showed you for our own country. Therefore, there is an urgent need to focus on implementing existing cost-effective policies and intervention if the world is to meet the target for Sustainable Development Goal and achieve a 30% reduction in premature mortality due to non-communicable disease. As you can see, the majority of etiology of cardiovascular disease are risk factors, which are modifiable. We can modify it, decrease weight, physical activity, and treat blood pressure, hyperlipidemia. Therefore, this is something that we really can intervene. The major challenge in prevention of cardiovascular disease is, of course, the fact that the people don't change their lifestyle very easily. They don't stop smoking, they don't increase their physical activity or decrease weight or eating healthier food. This is something that we tell it to the patient, but in practice, the people and patient cannot do it. The strategy for prevention are many strategies which have been discussed. One is to just treat the risk factor incidentally, which is not effective. Check everyone for risk factor on regular interval. And then this is, of course, expensive and is not possible in many developing countries. A better strategy, which high-income country can do it, like stratifying the population based on the risk score. This is also possible mainly in high-income country, but not again in developing country. A simplified model which can help, especially in low-income country, is based on non-laboratory risk factor using sex, smoking status, self-reporting history of diabetes, blood pressure, BMI, waist to hip ratio, and all of which can be obtained in one visit just by physical examination. This is a friendly risk score, which we have made several formula for it, which can put it in the mobile, and even an auxiliary health worker can do it. This is what we suggest that we should do according to this. And when we compare this non-laboratory based to laboratory based risk score, they are almost close to each other based on 10-year absolute cardiovascular disease risk, as you can see in this figure. One major problem is, of course, the pill burden, especially the old people who have hypertension, diabetes, hyperlipidemia, some heart problem. When they have to eat several pills every day, this is what we call it pill burden, and usually result in poor adherence. And the people who were supposed to continue their medication due to the number of pills, they usually don't do it. In 2003, Dr. Wald and Law, they suggested the Polypill, a strategy to reduce cardiovascular disease by more than 80%. It was very interesting because their analysis showed that the use of Polypill containing statin, 3 blood pressure or 2 blood pressure medication and half a standard dose, and they of course use also folic acid and aspirin, they can prevent up to 80% reduction in cardiovascular disease. This was just a meta-analysis, not a real study. And their hypothesis was based on the fact that elevated blood pressure and LDL cholesterol elevate. These two are the major risk factors for premature death. And when we can control these two, we can actually prevent the premature death. As a matter of fact, we did an analysis for Iran using Polypill, and we did also just a meta-analysis and mortality estimate that if we use Polypill, what happens in Iran. And we found that this, if we use just Polypill, we can decrease ischemic heart disease and stroke by 30 to 53%, which means that we can prevent 28,500 deaths and 12,700 deaths from stroke. The first one was from ischemic heart disease and the second one from stroke. Therefore, Polypill could prevent 41,200 cardiovascular disease in Iran. This was just our estimate based on this meta-analysis. This was published in the year 2012. And therefore, we decided to use this in Golestan cohort, and we thought it is an efficient, cheap, and also easy to apply. Behvarz can do it. We even don't need doctor to do it, because in Iran we have a public health network through all the country and being mainly managed by auxiliary health worker. We call them Behvarz. It's very practical, and it is people are very compliant with it. One pill instead of many pills, and cost-effective, significant saving in medical costs up to 80%. Therefore, we decided to do this trial, Polypill and healthy lifestyle to prevent premature deaths in Golestan Cohort Study. As a matter of fact, one of the drug companies in Iran called Alborz Daru, they accepted to prepare this Polypill for us. And this is the tablet of Polypill which we used in our trial. And the Polypill contains aspirin 81 milligram, atorvastatin 20 milligram, valsartan and enalapride either valsartan 40 milligram or enalapril 5 milligram, because enalapril occasionally produce cough. Therefore, we have a second polypill to use which contain valsartan, and also hydrochlorothiazide 12 milligram. This was actually our polypill, all in one tablet, given a daily dose in the evening. Enough evidence available. There was enough evidence for this combination in secondary prevention, but the evidence for primary prevention was questionable. Therefore, we thought we should do actually a primary and secondary prevention trial in Golestan Cohort Study. And we decided to use age as the major risk factor. Age alone can be probably the major risk factor that we can use it in our trial. And because having a complicated risk factor may be difficult. Therefore, in our trial, we used only age as our main risk factor. This was our team. And then we did first a pilot study, 475 patient, randomized, double-blind, placebo-controlled, 12 months with this combination to check the tolerability, compliance, side effect, effectiveness, and feasibility. This was published and showed that the study is feasible and the polypill is effective. We need a better design to cancel polypill, because polypill placebo made some problem in our analysis. We need two types of polypill, one without enalapril, because some people had cough with enalapril. And we should use a message by mobile to increase the adherence. And this is what added to our, therefore we designed the main study, about a year of weekly meeting and discussion with national, international scientists across the globe who were interested. And we finally developed this PolyIran trial, which is designed as a cluster randomized pragmatic trial nested in Golestan Cohort Study. The inclusion criteria was all people older than 50 who included in the Golestan Cohort Study, which we had about 31,000 people older than 50 in Golestan at that time. And exclusion criteria were contraindication to any component of this polypill. The pragmatic clinical trial had a more external validity than a placebo-controlled trial. This is very important. The trial may be valid and useful in the healthcare setting in which it was conducted internally, but have limited applicability and generalizability, while using a pragmatic clinical trial has a better external validity. And this was the reason why we choose this type of trial for our PolyIran. The trial detail can be seen here, but to make it short, Golestan cohort with 50,000 participants, more than 50, at that time, 28,000, more than 50 years, we selected a random sample of about 70,000 people from this 50-year-old rural participant, and then randomized them in two groups, one group polypill only tablet, and one group lifestyle only, without placebo. And we also choose 5,000 people in cohort who were just unusual care, like other people in the cohort. Therefore, study had 3 arms actually, and the polypill are 3,420. They were on polypill and lifestyle for 5 years, receiving regular visit every 6 months. The minimal care group, 3,417, received no medication, no polypill, non-blinded control, pragmatic design, received regular visit every 6 months in which some questionable and blood pressure was taken. And the usual care group, 50,000 from Golestan cohort subject, over 50 only received the usual care which other participants were. For this study was a control group received only minimal care, polypill group received both minimal care and polypill once daily. And the definition of minimal care was a package of non-pharmacological intervention, including blood pressure measurement, as well as education by text message to lose, to decrease the weight, to do exercise and other lifestyle recommendation. And Polypill tablet was one tablet, as I mentioned. The primary endpoint of our study were cardiovascular mortality, non-fatal cardiovascular mortality, hospital admission due to cardiovascular events. And this was study started and take 5 years to do this study. These are our auxiliary health worker, Behvarz, who were very well educated and were able to do blood pressure measurement and to do the follow-up. We had 300 auxiliary health workers who worked with us during this trial in the network of rural healthcare in Iran. And this was the design paper we published in European Journal of Preventive Cardiology. And the PolyIran Enrollment started in February 2011, and enrollment was completed in April 2013. And the follow-up phase was started and take 5 years. The protocol was to follow intervention group, the polypill group on month first, second, third, sixth, and then every 6 months. And for the control village, we just did 3, 6, and then every 6 months during these 5 years of follow-up. The follow-up was finished in year 2018. The result during these 60 months of follow-up, the polypill group had about 220 events, but control group had 301 events. And these results suggest that we had a 34% reduction in risk of cardiovascular event in purple group. This is the curve that you can see the difference between the control and polypill group. And the adherence was very good on the first year. It was about 75%. That we had some drop in the first year because of side effects, but then remained constant. About 75% of people were adherent to our polypill. And the effect of adherence was very important. The people who continue to take the pills, 70% of the tablet during 60 months, they have actually a 57% decrease in risk. As I told you, 34% for all, and those who were adherent with at least 70% of pill, they have a 57% decrease in their major cardiovascular event. The duration also very important, because when people take the drug for 20 to 34 months, again, the reduction was 32. Well, those who had 40 to 60, the reduction was 53%. Therefore, both the duration and the adherence was very important in better results. Therefore, side effects, it was very, very interesting that looking at major side effects like intracranial hemorrhage, peptic ulcer, upper GI bleeding, this was similar between polypill and placebo and control group. Sorry. And in spite of the fact that our polypill had aspirin, the intracranial hemorrhage, peptic ulcer, and upper GI bleeding were not different between the two groups. The paper was published in Lancet in 2019 with editorial and commentary and a press release. And this helped us that we were able to register this polypill in Iran, and it became in the pharmacies of Iran. And the people doctor can prescribe it now. And looking at other part of the world, there have been many studies on polypill, especially the Dr. Salim group and other colleagues and his colleague in the world. They did several studies on polypill. Therefore, we decided to do a meta-analysis. And with Dr. Salim group, we decided to do a meta-analysis, long-term randomized control trial of more than 1,000 participants and 2 years long. All of these, we just checked all studies. We found 3 studies which had more than 2,000 and had longer duration than 2 years. These were TIPS, HOPE, and PolyIran trial. These three trials, they did a meta-analysis. The total number of the study sample size became 18,162 for each trial, as you can see here, and all of their characteristics here in this table. And we have shown that both LDL cholesterol and systolic blood pressure would decline in all these studies. And as you can see here, the polypill group as a whole can be decrease the cardiovascular event compared to control. And we also look at this fixed dose combination, which we, again, is the same as polypill and control. Clinical outcome, as you can see between control and polypill or FDC, and the hazard ratio, which is, as you can see, both for CVD deaths, MI, stroke, revascularization, and close to 50%, 45% decline in all of these non-cardiovascular disease and also all-cause deaths, as you can see here. And also comparing with and without aspirin. And here we showed that polypill with aspirin is more effective and safe than polypill without aspirin. Therefore, this fact that studies have shown that aspirin may have bleeding, in these big studies, we really don't find it. And therefore, we recommend actually fixed dose combination with aspirin or polypill with aspirin, as we have shown it in our own trial. There were no major adverse events. The major adverse events were muscle pain, dizziness, and most of the people can continue this medication. This is also the meta-analysis, which was again published in Lancet last year. And we also did another very important study, and that was again Golestan Cohort in the city of Gombad, where we can do liver measurement like sonography and elastography. We did a study on 2,000 people, those who had fatty liver, and we gave them polypill. And we have shown, again, this paper was published in the European Heart Journal, and we showed that people who have fatty liver, when we give them polypill, the cardiovascular event in this group declined dramatically, about 50% decline, 45% decline in cardiovascular disease, and liver function also improved with polypill. Therefore, there is no problem with polypill in those who have liver disease. In conclusion, despite the modest difference in blood pressure and LDL cholesterol, randomized group, polypill can reduce fatal and non-fatal cardiovascular event. The rate is here, as you can see it. Larger effect in polypill, which include aspirin, benefit consistent at different metabolic risk factor, benefit appears larger in older population and well-tolerated and safe. Therefore, polypill treatment are a widely applicable, low-cost therapy prevention that substantially reduce the cardiovascular disease globally and improve healthy longevity. This is a term which is now being, you will hear it very much. Avoid between 5 and 10 million cardiovascular events a year. Assist in reducing UN Sustainable Development Goal to reduce the premature deaths by 1/3 in 2030. Polypill that reduce LDL cholesterol and blood pressure to a greater extent have more effect. Older people appear to derive greater benefit than younger people. This is recently published this week, actually. We had a report from USPSTF from America that multivitamins are not effective, and they had no effect. Over-the-counter multivitamin only in US are $13 billion every year. People are giving to eat this vitamin, which different and strong studies have shown that it has no benefit, and it may even have some side effects. We really need to recommend polypill instead of multivitamin and mineral to the general public. This would prevent premature death, and this is something that really very, one is very sorry for using so many money without any benefit on the health. Therefore, I would like to suggest the Polypill trial in cohort which are in IHCC and provide strong evidence. We can invite those cohorts who are ready to come, especially those from developing country. We do another trial in all these cohorts, providing strong evidence to prevent premature deaths, especially in developing country, provide evidence for reaching a UN SDG goal, will prevent premature deaths in, we also can prevent premature deaths in our own cohort, because our cohort participant could benefit from this polypill, as we did it in Golestan cohort. Thank you very much for your attention. I would be pleased to answer questions.
Thank you so much, Dr. Malekzadeh. That was really an elegant way of presenting, I guess, the reasons for the study, what you have done based on the cohort and the results of the trial. So thank you so much for sharing that with us. So maybe I can just start with a couple of questions. First is the adherence. So you've seen a much greater effect for those that adhered with the polypill and the duration. So how did you measure the adherence? How did you capture the adherence with the intervention? Was that a follow-up questionnaire?
Yes, as a matter of fact, we did pill count. As I told you, we had 300 auxiliary health workers in all villages, because this study was, the PolyIran study was just run in rural area. And in rural Iran, we have a health house with auxiliary health worker for every 1,000 people. And every participant has a Behvarz, and they were supposed to brought their tablets, and when they come to receive another pills, they just count the pills, and we had actually pill count by Behvarz.
Okay, great. So you had a quite exact, I guess, count of what the participants were taking. So you talk about the pragmatic nature of the trial and how, in a way, this could be done in LMIC, and you're looking for other cohorts. But can I just ask, with now very much increase in knowledge of the genetic factors, and this is one of your interests as well, whether if you're looking at high-income countries, using GWAS data could help us stratify, so not use age and the usual risk factors, but using GWAS data to risk stratify those that would need would be, I guess, eligible for the polypill.
The ideal thing is actually to use a risk score, including all those I mentioned. And even, for example, having cholesterol and LDL level. And the best thing is to have also the genetic data. The fact is that we still don't have those genetic data, but there is no question that the genetic has a very, very important role in cardiovascular disease. And if we have those data and we can add the genetic to the risk score, that would, of course, would be much beneficial. But at present time, especially for lower income country where there is still no data, I think we even can do it like what we did in Golestan cohort, and we can decrease up to 50% the cardiovascular event.
Thank you so much. I'm going to open the floor for questions. I'm going to also look if anybody had a question in the chat. I can't see anything, but if anybody has a question or comment, please just unmute yourself.
I would be pleased to also answer question by email. I have put my email also.
Oh, that's wonderful. I can see Latifa has a question. Please, Latifa.
Yes.
Yeah, actually, thank you very much, Alex, and thank you, Dr. Reza, for this excellent presentation. Yeah, you have mentioned that sometimes simple prevention, it's hard to implement, like when you mentioned to change the lifestyle of the population in terms to prevent the CVDs. And one of it, for instance, reducing the smoking and physical therapy. So were there any like advocacy campaigns, especially to educate the educators and the family and on the importance of doing physical therapy and changing their lifestyle? And yeah, so that's basically my question on this approach. Besides, of course, polypill is very good to prevent CVD, but what can be done in terms of the advocacy and on education, educating the population?
As you have seen, we did actually use the lifestyle education and by SMS for our control group. And we added polypill to lifestyle because we thought that not using lifestyle in polypill group is not ethical even. Therefore, I think the first step is, of course, the lifestyle. And we should always add lifestyle, even in the research, as we did in our study. But unfortunately, even in clinical practice, when a person comes with overweight, with inactivity, the actual life people, only 20% of people really change their lifestyle for different reasons. And this is especially more complicated in areas where, rural areas where the people are uneducated, or especially those who have the poor area, people who are poor. Therefore, we think that probably using polypill in addition to lifestyle would really help many people and would prevent disability. You see, just people who develop one-time MI or stroke, they become disabled for all of their life.
Changing mentality most of the time is the hardest part. Yeah, so that's why education is really important at early age. Thank you, Dr. Reza.
May I also ask, so you had a large number of rural villages who took part, and did you have part of, where the trial was active, where the villages were keen to take part and some where they wouldn't? And did you have any advocates or any champions from the community to really educate those that were going to take part in the trial into the efficacy and, in a way, the background knowledge, sort of how did that information disseminate? Because sometimes for the prevention trials, it is really the education and the messaging that's really quite key for any population, whether it's in LMIC or in other countries.
No, you see, the main point that, and the reason why I'm presenting it in IHCC is the fact that doing this type of trial should be done in cohort. See, nested in cohort, because in order to have Golestan cohort, we worked more than 10 years in Golestan, providing care for the patient. For example, that area was an area where esophageal cancer were very common. We established a clinic, we provided free service to all people, and the people in Golestan were trusted in us. And therefore, when you have cohort, and the cohort would educate people, therefore, this type of trial with this number of participants, with this follow-up, this is especially can be done and in a pragmatic way, which is more, have a very good external validity. It actually could be done in the setting of a cohort. This is not something that we just started the trial. We have the cohort participant. And we have obtained from all people consent. And the people were trusted on us. This is very, very important to establish this trust before you can do this type of trial.
Absolutely, completely agree. Does anybody else have Okay, so we have a question from Ella Mohebi, whether the polypill was efficient in the urban areas?
Yes, we also use the polypill in Gombat city. What was the question? Can you repeat it?
Whether it was efficient in the urban areas, not just in the rural
Yes, as a matter
setting.
of fact, as I told you, we did another study and we used the population in Gombat city, which is a rural, which is urban area. And on that trial, we used 2,000 people, 1,000 on polypill, 1,000 on control. And we measured the liver function test, sonography, elastography. And as you know, we were with the fatty liver, the major cause of death on those people are also cardiovascular disease. And this paper was published on European Heart Journal recently. And we have shown that the polypill is also effective in urban area.
Okay, great. Thank you. I don't know whether, yeah, okay, that was great to have that feedback. And I guess we can all look at the and the papers they've published. It seems that some key articles for all of us to get some further information. So I don't know whether anybody else had any other questions. I guess now that we've heard about this, it's, I guess, a call to the other cohorts who may be interested in discussing. And as you say, there will be probably lots of discussions to even start anything within other cohorts, whether they are more in a way in LMIC setting and the pragmatic nature of it, or in, let's say, in the US or UK or any of the European countries. So I think that we will keep this, so between Latifa and myself, we'll keep this as, I guess, a call to the cohorts if there's any interest to contact you if they have any wish to explore a polypill trial within their cohort.
Yes.
Great.
I would be pleased to be in contact with all the colleagues who are cohort PI and to help and support this type of studies in cohort.
Great, wonderful. So Latifa, I don't know whether you had any other announcements for the webinars, but it's been really great to have a number of people on the call today.
I was muted. Yeah, first of all, thank you very much, Dr. Malekzadeh, for this excellent presentation. And yeah, for the next webinar, we will be announcing it. It's coming soon for July. They're going to be the 7th webinar of this year. So I will keep informed all IHCC members about the dates and also the title of the talk very soon. And thank you again, everyone, for participating at this talk, and looking forward to keeping in touch with Dr. Riza if you have any other questions or comments. Thank you again, and have a great day or great nice afternoon, evening, everyone.
Thank you.
Thank you. Thank you for attending.
Bye.
Bye-bye.
Let's move into change.
Thank you so much once again.